Hello, everyone. First off, I'd like to thank the Global Alliance for Rapid Diagnostics inviting me to speak. I am Anthony Santarelli, a clinical research administrator at Kingman Regional Medical Center. And today I'm going to be telling you a little bit our story on what we saw in relation to the COVID-19 pandemic in our community and talk a little bit more about pandemics in rural America and illustrate for you the need for rapid diagnostics. So before we directly get into it, I'd like to introduce you to Arizona. Up on this map here, you'll see Arizona as a whole, and you'll notice Phoenix down in the center of that map. That is our major metropolitan area. Kingman itself is located in the upper northern west corner in a county called Mojave County, whose nearest neighbors for academic medical centers is, of course, down in Phoenix, a 3-hour drive, and up north in Vegas, 2 hours to the north. Mojave County in the whole comprises about 212,000 residents, spread out over 34,000 square kilometers of land area. And that does represent our service district. While there are other hospitals located in Mojave County, Kingman is one of the primary providers taking care of individuals from as far north as Colorado City on the other side of the Grand Canyon National Park, as well as small communities dotted throughout the area. Now, the geographical landscape that Kingman and Mojave County exist in is an arid desert. There's a large amount of sand and a large amount of aerial-borne particulate matter, which leads to our patient population to have a higher than national rates of chronic obstructive pulmonary disease. Typically, not one of the best chronic and comorbid conditions to be seen during the rapid spread of a respiratory viral infection. And before we get specifically into what we saw over the course of the pandemic, I'd like to just re-illustrate the time course of the pandemic and what small hospitals were operating with as they planned and prepared for the brunt of the waves. Beginning in January 2020, the first documented case of SARS-CoV-2 was detected in the United States in Seattle, Washington. In that same month, researchers made the gene sequence for SARS-CoV-2 available to the World Health Organization. The first rapid diagnostic antigen test was developed and granted emergency use authorization by the federal government in February. However, public health laboratories from around the country petitioned U.S. Congress for in-house validation and in-house test development, as the results from these were generally not as reliable as we would want them to be. Come March 2020, COVID-19 was declared a pandemic and a national emergency. And by April, it became painfully aware that hospitals, due to the lack of rapid diagnostic testing, hospitals and healthcare institutions would be left to manage their patient volumes or flatten the curve to best care and treat for their patients. At the end of May, cases in the Southwest United States began to grow in volume, and the first wave of cases peaked in Arizona at the end of July. However, come October, the beginning of the second wave of cases, rates of new cases in rural centers began to overtake those in metropolitan areas. So I'd like to show you, just illustrate a little bit more, how Kingman itself compared with its relative case volume to that of the whole state of Arizona. Over here on this graph from March 2020 to May 2021, on new cases per 100,000 individuals, we see that the peaks between small rural counties and Arizona state as a whole remain fairly temporarily locked. However, if we look from June to July of 2020, the cases in Arizona skyrocketed, and we only had a small increase in Mojave County and Kingman as a whole. However, by the time of the second wave of cases throughout December and January, we saw our number of cases increase to a degree which we were really unable to adequately care for. So we wanted to look a little bit more at this in detail. So what I'm showing you here is some data from one of our student collaborators, Dr. Eric Berg, which he presented at the Southwest Regional Emergency Medicine Conference, when he assessed the number of new cases per 100,000 individuals among all rural and urban designated counties in the Southwest United States, from California to Utah to Colorado, Texas, and Arizona. And what he saw that during the first wave from June to August of 2020, the rates of new cases were similar for both urban and rural centers. Of course, the presence of supplies and major academic medical centers desegregate between these two counties fairly reliably. However, at the emergence of the second wave from September to November, the number of new cases that we were seeing in rural America began to outpace that which was occurring in cities. Of course, this does desegregate along state by state lines, and as you can see, I have Arizona and California presented here for you broken out. In Arizona, it seems like rural counties saw the preponderance of spread throughout the entire wave. However, the inverse of that is true for California. So with these number of cases increasing throughout rural America and the resources not being readily available at small community hospitals, our patient volumes began to overwhelm what we were able to provide. And just to kind of show you that, I'm going to show you some data here by one of our nurse scientists, Heather Miller, who wanted to map on the typical utilization of our emergency department resources for trauma, you see here in red for 2019 and in blue for 2020, against those of the cases coming in for testing for COVID-19. And we see that though a huge spike in the number of patients that we saw coming to our emergency department for diagnostics occurred in July of 2020, the rates for trauma-related illnesses did not decrease, and that's fairly stable for the rest of the typical causes for concern that brings patients to the emergency department. Moreover, when patients came to the emergency department, because of closures and overloading in local and other hospitals and transfer sites, patients came here and we were unable to transfer out the same volume we were able to before, leading to an increase in patient flow and a reduction in all transfers by 21.4%, requiring bed stays, provider care, nurse care, and of course, staff care. So with these loads beginning to overwhelm our hospital system and many hospital systems in the United States, what did we specifically do to try and mitigate this? Well, the first thing that we determined to be critically essential was to predict the actual prevalence of COVID-19, try and understand how many people in our service district were infected and how many people in our service district have already recovered. So to do that, we recruited a convenient serial sample of individuals from our entire service district, accumulating to about 1.13% of our annual patient visits. And then we brought them into the hospital and administered them an IgG antibody test. And the first question we really wanted to ask was, what was their relative amounts for the individuals testing positive for antibodies, anti-SARS-CoV-2 IgG, against those who had received a molecular PCR diagnostic test? And what we found among the individuals testing positive for antibodies was only about 44.4% of them had ever received a reliable diagnostic. This, of course, occurred fairly ubiquitously across our sampling demographics, be they of typical age, which we see somewhere between 43 and 51, men, women, and of course, individuals in the healthcare sector. So with individuals in the healthcare sector testing positive for COVID-19 antibodies, we really wanted to determine the impact that it had on our providers in the area. And I'm showing you some data published here by Clevborough et al. Just to drive home the point that active work with COVID-19 patients does lead to about a twofold increase in the odds of contracting COVID-19. And we in fact saw the same thing within our data, where general members of the public were seropositive for SARS-CoV-2 infection at a rate of 5.7%, where individuals in the healthcare sector were seropositive for SARS-CoV-2 at a rate of 9.9%. Not only were they getting sicker with COVID-19 at a higher degree than the individuals we were taking care of, but they were also reporting high levels of stress and reported levels of feelings of isolation, leading to a large number of healthcare providers calling out sick and being sick and unable to perform the duties of their job, leading to a reduction in our resources. So the hospital began to initiate procedures to minimize provider contractions of COVID-19 and maximize their ability to take care of sick individuals in our area. And the first thing that they did was try to diagnose patients remotely. Now, this is not through the use of a standard diagnostic test, but this is providing one-on-one contact with visitors through the rollout of a telemedicine program. And we, in the clinical research department, wanted to assess its relative efficacy at reducing our patient volumes and its actual utilization. So what we saw first was that following the upscale of our telemedicine program, we saw about a 10% reduction in total ER volumes over the time period studied, and a massive use between pre-advertising and post-advertising of a telemedicine program largely comprised of individuals seeking clinical guidance on upper respiratory infection like symptoms and whether or not they should come to the hospital for a test. With this many people wanting to know whether or not they were positive or negative with COVID, our hospital administration staff made it a point to provide relief to our overworked healthcare employees. Here we see a picture of our CEO meeting with FEMA directors who made available federal resources to come in and assist in the administrations of treatment and diagnostics for patients. Not only did we receive help from the federal government, we had to recruit heavily from traveling nurses to take care of to fill all the shifts of nurses calling off sick and actually being sick, not being able to come in and do their job. And then finally, we had needed to create places to test and treat. With this high volume of individuals wanting to come in and determine whether or not they were actually positive for COVID-19, we constructed a series of tents in and around the hospital where they could come in, receive a diagnostic test, and then receive any emergent therapeutics, which we'll talk about in just a moment. Of course, we did this all with the primary goal that we know that speeding up delivery of novel medications improves patient outcomes. And I'm going to show you just two small pieces of data here. One for inpatients, if they get sick, come to the hospital. The sooner we're able to administer a course of treatment, the better their outcomes tend to be. So right here, I'm showing you some data presented by Taz Brinkerhoff, one of our resident scientists, who assessed whether or not the administration of convalescent plasma, in addition to dexamethasone and remdesivir, improved patient outcomes whenever they were diagnosed and shifted into the hospital within 2 days. And he did indeed seem to find that triple therapy did improve patient outcomes and keep them alive longer in the hospital. And then secondly, for our outpatients, all those individuals wanting to get tested, those two testing positive were able to be administered a series of monoclonal outpatient antibody therapies. Here I'm showing you data relating to bamlanivimab. However, we have also administered Regeneron. And though it does not decrease their hospitalization rates for individuals administering this quickly, it does provide them with a robust enough immune response that they do not require to come back for direct care in the emergency department. So since rapid diagnostics can be rolled out across a large land area and population size, and early diagnostics are directly related to improved patient outcomes and minimizing the reduction in healthcare employees available to take care of those populations, really the need for DNA-based rapid screening or reliable testing diagnostics is now. As a number of COVID-19 variants begin to grow and desegregate along state by state and regional boundaries within the United States, there needs to be a developed procedure that can test for these variants and determine outcomes and help aid and guide our clinicians to provide the best treatments on a genetic basis. Of course, there is cause for concern. This is not the first time a news article like this has popped up, but some new coronavirus variants are appearing in France from about 3 days ago, I think, on this one. It appears to bypass PCR tests. We don't really know much more about it, but I think it would be important to further elaborate on. Just before I finish, I'd really like to thank our collaborators in the Kingman Area Research Consortium, from our faculty advisors to our resident physicians, our nurse scientists, and our student trainees. I'd also like to thank our supporters at Kingman Regional Medical Center, the Foundation for Osteopathic Emergency Medicine, and then our university collaborators at Pacific Northwest University, Midwestern University, and Rocky Vista University. Thank you, everyone.